later, and I'm going to record to the iCloud. So thank you so much for joining for today's Tuesday topic, cardiorenal syndrome. And let me share my screen with you. Perfect. And thank you very much again for your patience. So I'm going to build this around a patient. So our very first patient is a 45-year-old female who presents to our hospital with complaints of worsening shortness of breath over the past 2 weeks. She's got orthopnea. Remember what orthopnea is, that you actually have to use pillows to elevate your head because you can't breathe. Her heart is beating quite fast. She has massive 4+ bilateral lower extremity edema. And she's saying that she thinks she's gained about 20 pounds in the last 2 months, but she hasn't really weighed herself. She just knows that her clothes don't fit, her shoes don't fit. She's having a struggle. Now, when we examine her, we agree she's morbidly obese. She has very significant jugular venous distension without collapsing her neck veins, even when sitting at 45 degrees. She has bibasilar crackles, bilateral lower extremity edema. Remember, it's 4+ edema and extends all the way up to her torso. And she has venous stasis ulcers. And by the way, to complicate matters even more, she has an irregular heart rhythm. So when we weigh her today, she weighs 345 pounds or 156 kilograms. And the last time she was weighed in hospital or in clinic was 3 months ago, and she weighed 276 pounds. So she's gained almost 70 pounds, right? Almost 70 pounds. And when we evaluate her, we see her BNP is quite elevated. Remember, greater than 200 indicates significant heart failure. Her troponin is normal. It's less than 15 nanograms on her high sensitivity. Goodbye. Thank you so much. We'll see you in the morning. Yes. And her creatinine is quite elevated. So 1.7, previously it was 0.8. So by KDIGO guidelines and the ACAN guidelines, we would actually see this significant 100% increase in her serum creatinine as being indicative of renal failure. When we look at her EKG, we see she has atrial flutter with a heart rate of 157. And on her chest x-ray, we're going to see some curly B lines. We see that she's got CHF, she's got bilateral pulmonary infiltrates. And remember those curly B lines, which are the lines that actually go down in a vertical perspective down towards the diaphragm, and they actually are indicating to us very significant vascular congestion. So we're taking a look at her EKG, and you can see this EKG might not have recognized. You would look at it and you might think, it looks kind of abnormal. I'm not really sure. She has a rapid ventricular response. But remember, with atrial flutter, when you have a patient who has atrial flutter, if you turn the EKG, you just turn it upside down, between the R waves, that will look exactly the same. And she has 2-to-1 flutter, 2-to-1 conduction of atrial flutter. So always remind yourself, always, when you have a patient with new onset AFib, new onset atrial flutter, the first thing that you're really going to focus on is that they have volume overload in the right and or the left atrium. That volume overload in the atrium and the distension of the atrium actually stimulates abnormal responses in the muscle tissue itself. So one of the biggest issues that we see with patients who have atrial fib or atrial flutter is that they have a high BNP. If we were to look at them by echo, we would see that their atria is quite dilated, and that would actually assist us in making a good diagnosis and an evaluation of the patient. So now, if you look right here, you're going to see these lines that kind of stretch upwards from the base of the lung, and these lines stretching upwards is what we call curly B lines. Curly is not C-U-R-L-E-Y like curly hair, named for the physician who annotated this. That's K-E-R-L-E-Y, curly B lines. We also see that the patient has a really large heart. She has vascular engorgement, and that vascular engorgement here is showing you that pulmonary vascular congestion. These are the orange lines, and the blue lines are showing us these bibasilar infiltrates, which is actually indicating to us that she's got some effusion and that she has atelectasis. All right, so starting off with that case, this is such a great case, and it's very common, a common type of patient that we often will see. Let's really think about this as it relates to what I always like to talk about is crosstalk. We have heart-brain crosstalk, we have heart-kidney crosstalk, and heart-kidney crosstalk is called cardiorenal syndrome. So what is that actually? We've been discussing cardiorenal syndrome for about 25 years, and really first identification of cardiorenal syndrome actually gave rise to the understanding that the disorder of the heart affects the kidneys and a disorder of the kidneys affects the heart. So acute and chronic dysfunction of one organ will eventually evolve into that second organ dysfunction. Well, that makes a lot of sense to us because the heart, of course, is providing the perfusion to the kidney, but the kidney is regulating salt and water. So when we have kidney dysfunction, we will have in a backwards direction, we'll have cardiac dysfunction. And when we have cardiac dysfunction in a forward direction, in terms of looking at blood flow dynamic, we're going to see kidney dysfunction. Now, this has been present in literature about cardiac and renal dysfunction for, like I said, 20 years as a recognized syndrome. But we as clinicians are not always evaluating nor recognizing this. So I want to just talk about this like a high school girl like Sandy in Greece and her really bad boyfriend. This is a codependent relationship of the heart and the kidney. And what we're going to remember is the filling of your ventricles is dependent on the regulation of salt and water. So the kidney, of course, is regulating the excretion or retention of salt and the excretion or the retention of water. And so cardiac flow significantly dependent on salt and water regulation by the kidneys regarding that resuscitation and that mobilization. So cardiac flow, cardiac filling volume, the preload of the heart, the filling volume and the distension of the ventricle is profoundly dependent on salt and water regulation by the kidney. Now that's partially hormonally controlled and partially just related to hydrostatic pressure in the kidney. Fantastic, okay? But the kidneys are absolutely dependent on volume and pressure, which is blood flow, which is, of course, determined by cardiac ejection, your stroke volume, your cardiac output. So I want to make sure we appreciate dysfunction of one is typically going to be followed by dysfunction of the other. Heart failure first, kidney failure second, kidney failure first, heart failure second. These disorders actually are profoundly and intimately related. And the sooner we're evaluating our patients, the sooner we're recognizing this crosstalk between the heart and the kidney, the better off we can, the better that we can manage our patient and protect them from this dysfunction. So if I think about pathophysiology of cardiorenal syndrome, exactly what I've just said. First of all, the hemodynamic component, which is an alteration in ventricular ejection, decreasing systemic perfusion, thereby decreasing the renal blood flow, and your kidney is very dependent on volume and pressure. The high efficiency filter of the kidney, which is the glomerulus, depends on volume and pressure and pushing for filtration. And the tubules of the kidney are very dependent on oxygen delivery. But if I don't have volume and pressure through the filter, I'm not going to have adequate oxygen delivery at the tubule. So what actually happens when I have a reduction in this volume and pressure to the kidney is the kidney will lose its autoregulation capability. And what you start to see is an engorgement of the central veins, and central venous pressure starts to go up. Now we're going to call that from now on, I'll probably use the word CVP, but what I really want you to think about is venous congestion. Neck veins distended, bilateral pitting edema, my veins are congested with volume, the volume is escaping into the interstitium, and when that occurs, that very significant and profound venous congestion, you're actually going to cause renal overload. When you cause renal overload, because you've got so much venous engorgement, your renal function is going to decrease. So one of the things I want to remind you, and I think it's such an important thing to hear for all of you, is that in your intensive care unit, when your patient has a central line, you don't need permission to monitor the brown lumen for your CVP. CVP is not a volume number, and it never was. But when CVP goes up, what that is telling you that you have venous congestion. As soon as you have venous congestion, it's going to become likely that you are going to actually start to exhibit some renal dysfunction. Now, as you have venous congestion, you'll also have fluid flux into the abdominal vault As fluid fluxes into the abdominal vault, you'll start to see compression of the arteries for all of your abdominal organs: kidney, liver, spleen, stomach, colon, large intestine, small intestine. You'll start to see compression of the arteries. And as you see compression of the arteries, you have reduced blood flow and therefore can start to have ischemic injury. Oh my God, it's so incredibly important for us to monitor. Okay. Now there's also some non-hemodynamic complications that promote cardiorenal syndrome. And those are primarily mediated by sympathetic nervous system discharge, a very high level of sympathetic nervous system activity, the renin-angiotensin-aldosterone axis, which promotes salt and water reabsorption, and arterial constriction. Activation of aqueous vasopressin, which actually is made in the hypothalamus, but is released from the pituitary gland, which will further exacerbate renal dysfunction. And in addition to that, all of this is going to start to cause an inflammatory injury and systemic inflammation. And those cytokines that are released are actually going to start to cause some renal damage as well. Now, this is a really nice visual. It's very complex, very important to look at what's happening here. Okay, so first of all, I have an acute cardiac insult, or I have an acute kidney insult, either one. But I'm going to start to activate sympathetic nervous system. And that means that I am stimulating the kidney, or I'm stimulating the heart with sympathetic activity, aqueous vasopressin, which is also hormonal. And then I'm going to start to see all this hormonal or humoral activation. And there's a lot of it. So hormonal activation in beta natriuretic peptide hormone, hormonal activation in aqueous vasopressin, hormonal activation in aldosterone and angiotensin. So let me make sure you understand this. Water and salt, vasoconstriction, 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 and water and salt. So I'm constricting my vessels and retaining water and salt. But despite the fact that I have all that volume, my heart is unable to mobilize, either because I have a primary cardiac dysfunction or I have a primary renal dysfunction, which in a backwards direction has caused a cardiac insult. In either case, the heart is failing and the kidney is failing, and they are communicating together at this dysfunction. And when we don't step in to control this, and the best thing that we can do, my friends, almost 100% the best thing that we can do, is actually look at a renal perfusion pressure or the perfusion gradient. Because what we want to monitor is MAP, which you do all the time, and CVP, which you do some of the time. Even though you've got triple lumens, you might not be connecting them to pressure tubing or the monitor, but you should be. And then the MAP minus the CVP, which actually is going to give me perfusion pressure. MAP minus CVP gives me perfusion pressure. And as your CVP starts to go up and your MAP starts to go down, you can 100% guarantee that you're going to infarct your kidney. So that seems really important to me. This is something I can do as a nurse. Not much I can do about inflammatory signaling. That is just the promotion of the inflammatory cascade, most particularly related to cytokines. And cytokines actually can cause very significant renal tubular dysfunction, making the tight barrier of the renal tubules open, destroying the border of the renal tubules, which is called the brush border, which then causes failure of regulation of urine and regulation of waste products. Oh my goodness. But the thing I'm most concerned about for us is my volume pressure gradient. MAP minus CVP equaling perfusion pressure. Got to keep it greater than 60, which means get CVP down and MAP up. That's what we're going to do as bedside nurses. Now, I want to just remind you about simple glomerular function. And I mean simple. This is really simplified. This is a simple drawing that I designed, so it really tells you it's simple because I'm no artist. Your blood enters on the aortic side from the afferent arteriole, enters into the high efficiency filter, the glomerulus, and that is volume and pressure dependent. Okay, and you have an autoregulation cascade along a certain amount of pressure and a certain amount of volume that the kidney will regulate itself. If you overwhelm or underwhelm, you're going to have kidney failure. The blood that enters here is dirty, dilute, electrolyte rich, and oxygenated. Push, 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 pushing out particles, pushing out waste products, pushing out water, and that's all captured in the bowl of the Bowman's capsule and descends down into the tubules of the kidney. So everything that I filtered here, water, waste, electrolytes, goes down into the tubules, and the tubules are entwined with capillaries. Those capillaries arise from the blood that exits the glomerulus, that's the efferent arteriole. That blood is clean, it's concentrated, it's electrolyte poor because we push all those electrolytes out of the filter, but the blood is still quite oxygenated. And then that gives rise to the peritubular capillaries, which actually surround the tubule. And this is where you're going to use oxygen, where you reabsorb into the blood that which you want and you secrete from the blood that which you don't, typically all transported by oxygen to regulate my patient's blood. So now the blood exits in the venous circulation and it's clean with perfect concentration, perfect electrolytes, but it's deoxygenated because we use the oxygen at the tubules. So again, I want to remind you, the glomerulus of the kidney, the filter, this is what you replace with hemofiltration. The filter of the kidney is driven by volume and pressure. The tubules of the kidney, are driven by oxygen utilization. And this is what I replaced with dialysis, filtration and dialysis. Okay. So again, glomerulus is primarily volume and pressure dependent, and the tubules are primarily oxygen dependent. And remember, if I don't have adequate volume and pressure, I will not have adequate oxygenation. So when I see pre-renal failure, that's what I'm going to start to see with cardiorenal syndrome type 1. First, I have pre-renal failure, which means failure of volume and pressure, because I have cardiac dysfunction. So once I see pre-renal failure, I want you to think about that as unstable angina. And ultimately, that's going to end up with kidney infarct. So it's like a myocardial infarction, where I now have dead tissue in the renal tubules, and my patient now is dysfunctional. Okay. So in the ICU, this is something you've got to be considering. You've got to be looking at cardiorenal syndrome. And I'm really only talking, there's 5 types, but I'm only talking about type 1, which is acute kidney injury or acute on chronic kidney injury in relationship to cardiac failure. And most commonly, it's going to be acute decompensated heart failure. So again, we just quickly consider all the things that happen when we have acute heart failure. The heart is volume overloaded. We have decreased cardiac output. We basically have arterial hypovolemia because the arteries are hypovolemic. The veins are hypervolemic, but the arteries are hypovolemic. My MAP goes down, but my veins are hypervolemic and I have an elevated CVP. And this goes on to cause an increase in my renal veins, which then causes congestion at the kidney and causes a decrease, of course, in filtration and causes tubular injury or renal tubular injury. And then you look here, you have worsening WRF, worsening renal failure. So when we're not controlling heart failure, we will insult the kidney and we will have worsening renal condition, worsening renal failure. And all of our therapy begins, unfortunately, often begins because you've got worsening renal failure. Now I'm going to put you on CRRT or hemodialysis if you're stable. But what about all of the warning that you had prior to that time? You had a lot of warning, and that warning was given to you actually because you had arterial hypovolemia, which meant your MAP went down, your pulse pressure was narrowed, your stroke volume went down, your arteries are hypovolemic, and your veins are hypervolemic. And you know how you know that? Jugular venous distension, bilateral peripheral edema, abdominal hypertension, but most simply, your CVP went up. MAP down, CVP up. This is pretty simple, my friends. It's a very complex interrelationship, but it's simple for me at the bedside. You've got a triple lumen. I'm going to monitor your CVP. So CVP is really going to give us a projection of central venous congestion. Now, remember, I said this isn't really about volume. because we're assuming when the CVP is high that the patient just has too much volume. But most of the time when the CVP is high, you have a lot of venous volume, but you don't really have arterial volume. And that's really the case. That's one of the reasons that with a person with acute decompensated heart failure, we might consider an inotrope. We might even consider an inodilator. We want to move that volume forward into the arterial bed and get it out of the veins. But the first thing we're going to do is we're going to monitor your CVP and watch the process of central venous congestion. This is a measure that for many reasons is very helpful. But you as the bedside nurse have to be sure that you know you're not monitoring CVP as a volume indicator. You are monitoring CVP as a venous congestion indicator, and that is going to really help you. And in this case, MAP becomes even more meaningful. MAP minus CVP is going to give you renal perfusion pressure. If that perfusion pressure is so straightforward, MAP minus CVP needs to be greater than 60. Anytime it's less than 60, it's going to associate with acute kidney injury progression. So by the way, my friends, if I can help my patient protect them from de-evolution of kidney function, why the heck wouldn't I do it? And it's really quite easy. So we're going to use CVP as a primary key component of mean perfusion pressure. So you might have seen this drawing before. I show it a lot. It's one of my drawings that I use a lot when I talk about hemodynamics. I want you to remember that your LV ejection and your mean arterial pressure, which is primarily a reflection of vascular tone, actually must overcome the resistance of your central venous pressure. This is resistance, and this is forward flow. MAP minus CVP, and that gradient must be greater than 60. Anything less than 60 actually is highly linked to renal dysfunction and mortality and morbidity. Okay, well, great. So what does that mean? It means when my patient's CVP is going up and my MAP is coming down, I have a much narrower perfusion gradient. MPP, mean perfusion pressure. MAP minus CVP has gotten narrow. I want to do two things. I never treat just one. I've got to do both. I want to get the CVP down and I want to get the mean arterial pressure up because I want to widen that gradient so I have a better blood flow dynamic. So my LV ejection, even if it's poor, is able to overcome that terminal resistance, which is the CVP. Seems so incredibly straightforward. So MAP reflecting stroke volume and forward flow, and CVP, which is determining the resistance to the ultimate filling of the right heart, which is at the end of the circuitry. Really profoundly important. It is now considered that a high CVP has a greater impact on progression of acute kidney injury, even more important than your MAP. CVP tells you about venous congestion. Okay, so you could use the term, if you like, venous hypervolemia, but typically with venous hypervolemia and venous congestion, I have poor forward flow and I'm arterially hypovolemic. So by the way, just putting a vasopressor on this patient to get their blood pressure up is not really going to improve their outcome. I want you to remember that the kidney consumes a lot of the cardiac output. 20% of the cardiac output goes to the kidney. It's second really only to the lungs. The lung receives all of your cardiac output. The kidney receives 20% of the cardiac output and 10% of that 20%. So if my cardiac output is 5 liters, 20% is 1 liter. 10% of that 1 liter, which is 100 cc's in the example I gave you, 10% of that 20% of cardiac output actually is delivered to the microcirculation supplying oxygen in the medulla. So it's a really small amount, and your kidney autoregulates against a given grain. When the blood flow falls, your kidney is going to regulate by shifting blood flow to the microvasculature. And so the first thing that you see is the patient's urine output starts to go down. Now they've shunted their blood flow to the microcirculation to preserve tubular function, but that's only along a given autoregulation method. And eventually that's going to fail. And that is going to fail. And I want to make sure you appreciate Your kidney is volume and pressure dependent for the glomerulus and oxygen dependent for the tubules. But if volume and pressure of the glomerulus goes down, eventually oxygenation at the tubules will decrease and your patient will be significantly and profoundly at risk. Hang on one second. Okay, so when we think about acute kidney injury and acute renal failure, I want to remind you ARF, acute renal failure, failed as in an F. Nobody wants to get an F on their test, and we don't want to fail our patients in this way either. So really important for us just to remember AKI, KDIGO guidelines, all the things that dictate to us about failure of the kidney, tell us about the increase in the serum creatinine. So increase in the serum creatinine to greater than 1.5 or 1.9. Remember our patient, 1.8, okay? And when urine output is going down. So we're looking at the increase in serum creatinine, the decrease in glomerular filtration, and the decrease in urine output. By the way, number one thing, apart from your CVP, is you need to monitor hourly output, and you need to monitor daily weight. Hourly output, daily weight, CVP. These are things me as the bedside nurse can make a commitment to monitoring and managing in order to protect my patient. So again, I want to remind you, if you have low volume and pressure to the glomerulus of the kidney, you are eventually going to infarct your tubule. This is known as pre-renal dysfunction. Doesn't mean your patient is not in acute kidney injury or even acute kidney failure yet. It means the cause is before the kidney. And by the way, that should be something we can manipulate. We need you to have a good stroke volume. We need you to have a good MAP. We need you to have a low CVP so that we can try to maintain a perfusion gradient to the kidney. Now, your kidney can suffer about 15 to 20 minutes of reduced volume and pressure. But ultimately, you're going to have a kidney infarct. And when kidneys infarct, that's when we really start paying attention. Now your creatinine is 3, now your creatinine is 4, now your creatinine is 5. Why are we waiting so long? And part of the reason we wait so long is because we're not staying on top of this information and sharing it appropriately with our physicians. So now we go back to that original visual, right? I have reduced volume and pressure and a reduced MAP. I have much less blood volume going into the glomerulus and much less blood volume coming out. And I am actually hypoxic. So now you can see what's happened here is I've just shunted my blood flow. First, I shunt my blood flow, and then I actually have destruction of the renal tubules. So now what I'm going to see is I can't clean my blood. My blood exits the kidney. It's dirty. It's dilute. It's electrolyte rich. And this is bad blood. Bad blood. Taylor Swift sang a song about bad blood. She didn't really say bad blood. I say bad blood to the Taylor Swift song, but really important for us to remember this relationship when we're thinking about cardiorenal syndrome, and in particular, cardiorenal syndrome type 1, which is what typically happens in the ICU patient, whether they have acute decompensated, whether or not they have an acute decompensated heart failure. So really, really important. Now, our number one goal here is to try to decongest our patient. Reduce venous congestion. So first thing we're going to do is we're going to give diuretics. Okay. Patient responds or they don't respond. They don't respond, we're going to increase their diuretic. We're going to increase our primary diuretic, just like you do with Levophed. You increase Levophed to maintain mean arterial pressure. I'm going to increase your diuretic in order to try to improve diuresis. If that diuretic that has been increased doesn't work, I'm going to add a second diuretic. Okay. And I'm going to add another diuretic. I'm going to add more diuretics, but at some point, I have to say my patient has diuretic failure. So let me remind you, if your patient's got diuretic failure, here's what's going to happen. You're going to place a VAS cath. Okay. So for me, this is what's going to happen. You're going to place the VAS cath and you're going to perform basic scuff, which means the patient is going to drive his own filtration, and we're going to remove fluid so that we're going to decongest his veins by removing fluid. Now, if you're not in an ICU, you might be able to do this with something called aquapheresis. I, as a person who really loves the kidney and I really adore CRT, I think it always needs to be under the control of a nephrologist. So I really want you to get a VAS cath. I might put you on your CRT device and put you in slow, continuous ultrafiltration. So I'm not really using therapy fluids. That's what I do normally when I'm doing CRT. I'm just allowing the patient to drive his own ultrafiltration. But I'm also going to have to move that forward to actually complete renal rescue and purifying the blood with CRT or hemodialysis. If I've had a patient that doesn't respond to diuretics, he's still profoundly volume overloaded, he has heart failure, he has an elevated BNP, a decreased urine output, and an increased serum creatinine, CVP is up and MAP might be down, or maybe I even got the MAP up, but the gradient is less than 60. I need to decongest this patient. So diuretic 1, increase diuretic 1, add diuretic 2. By 24 hours, I should see that the patient is actually diuresing in response to the diuretic therapy. My responsibility is I'm counting cc of urine you put out every single hour. I'm adding that up together. I'm reporting that to my attending physician, my APP, and my nephrologist, because I need everybody to be on the same position. As if my patient is not responding to diuretic decongestion, I'm going to have to ultrafiltrate. Okay, so let's go back to our patient. She gets placed on an norepinephrine drip and gets titrated up for hypotension. She's administered one-time dose of 20 milligrams IV furosemide for her volume overload status. She's gained a lot of weight. We see the fluid in her periphery. We see it in her neck veins. And by the way, her initial CVP is somewhere around 30. Okay, that's really bad. Even if I get her MAP up to 70 or 80, I still don't have a perfusion gradient that's adequate to maintain renal perfusion. Got to get her CVP down. Now, on she goes, she gets admitted to the ICU. She's got acute hypoxic respiratory failure. We start her on 6 liters nasal cannula. Remember, CVP is 30. She has an echo. She has a 35% ejection fraction. She had a normal ejection fraction 6 months ago. She's got tricuspid regurg, mitral regurg, pulmonary hypertension. She now being diagnosed as having cardiogenic shock. So she had an acute decompensation of her cardiac function, secondary to her renal dysfunction. And now she's in cardiogenic shock. Now we're going to give her some more Lasix. Now we're going to give her 40 milligrams every 4 hours. She's been placed on beta block to block some of that sympathetic activation, which is causing more stress to her myocardium. She's on heparin drip because she's got atrial flutter. We're going to protect her from having clot formation in the left ventricle or the left atria, where that clot could go up into, of course, into carotid arteries, and that's our biggest concern for this patient. And now we see is we have to put her on high flow oxygen. So remember, we put you on high flow oxygen because you're hypoxic, and also we put you on high flow oxygen because that washes out the dead space of carbon dioxide, which is from your mouth to your primary airways to your respiratory airways. All the gas that is in there is CO2 rich. So on high flow oxygen, I wash all of that CO2 out. So I'm not really treating your carbon dioxide with high flow. I'm really treating your hypoxia with high flow, but I'm washing out that dead space CO2. So it's a really nice methodology. We can go up to 70. Sometimes we've even seen 80 liters. And what's so wonderful about it is I'm giving you a very high flow of oxygen at a prospective FiO2, 30%, 40%, 50%, 60%, but I'm also humidifying the oxygen. So I'm not drying out your mucous membranes, and it's much more comfortable for patients than CPAP or BiPAP, and certainly better for patients than intubation. Okay, now she's on day 3. Now her CVP is 35. She has not responded to my diuretic therapy. Her creatinine, remember, initially was 0.8, went to 1.7, and now it's 2.6. She has a bicarbonate of 15, which means she has a base deficit of around -7. Bicarbonate base go down, that always tells you metabolic acid is up. She's got metabolic acidosis, primarily related to lactic acid because of hypoperfusion, and her serum potassium is elevated because the kidney can't clear her potassium, the kidney can't clear the metabolic acid, and the circulating metabolic acid in the blood is moved inside the cell, and the cell is releasing potassium. So my patient's potassium is going up, but I have renal dysfunction, so I can't clear that. And the metabolic acidosis makes that potassium worse and worse and worse. She's only put out 400 mils. over the first 3 days. So she's gotten a lot of diuretics, still isn't making urine. Her increase in BUN and creatinine, an increase in the proportional ratio of BUN to creatinine, she has pre-renal failure. And we are now going to call this type 1 CRS or cardiorenal syndrome, which means if we're lucky, we can protect and resuscitate this patient. So at this point, the decision really has to be, do I increase her diuretics? She's already had 3 days of diuretics and she's not getting better. Here's the time I want a VAS cath. If I can't do a VAS cath and I'm working primarily with cardiology and maybe depending on your hospital, I could put in a midline and actually perform aquapheresis. But either way, if I put in a VAS cath, I put her on SCUF, slow continuous ultrafiltration, or I put in a midline and I put her on aquapheresis. My goal is to remove volume from the veins. And if she drops her blood pressure, I'm going to treat that with a vasopressor. I have got to get volume out of her veins. I must promote decongestion. I cannot improve this patient's outcome if I don't do that. So the decision is made to ultrafiltrate. So on the 4th to the 6th day, we're just ultrafiltrating. We're not doing CRT. We remove 4 to 6 liters per day. Now, remember, she's gained 70 pounds. Okay. So 70 pounds is close to, I'm just guesstimating, around 22 kilograms. For every kilogram, you are a liter positive. She is 22 liters positive. Is she unstable? You bet. Might she drop her pressure? Yes. But keeping her venous congestion in place is harmful. So we're going to remove her fluids and we're going to manage her pressure, because remember, as we remove fluids, her CVP will start to come down, and we're going to control her pressure with vasopressors. By the way, that's not an easy thing for me to say because I don't really like vasopressors. I think they misguide you as to your therapeutic intervention for your patient, but okay, that's okay. All right. So now we wean her off high flow oxygen gradually to nasal cannula and then to room air. By the 6th day, she's off of oxygen support. And by the 6th day, her serum creatinine has gone from 2.52 to 1.81 down to 1.50. Oh my God, we resuscitated this patient. We actually returned her to a normal function. 7th to 12th day, she's getting intermittent hemodialysis for ultrafiltration. Vasopressors were weaned down to off by day 9. On the 13th day, ultrafiltration was discontinued. And on the 14th day, she was discharged home. Now, this is because we had a really good communication at the bedside, because we were looking at our data appropriately and really trying to make great decisions. So I have a second patient. I don't know how quickly we can get this patient done, but this is the patient who has primary cardiac failure, who ends up with acute kidney injury and a type 1 cardiorenal syndrome. Patient admits into the emergency department, has a historically poor ejection fraction, 15%, hypotensive, very lightheaded, vomiting, had symptoms for a couple of days. He's dizzy, he doesn't have chest pain, but he's short of breath and he has palpitations whenever he lays down. Now, you know, when you lay down, you deliver more volume back to the heart. And if you have a lot of volume, you're going to stretch that atria. You're going to have a lot of premature atrial depolarization. Might have some AFib, might have some A-flutter. So patient basically is primarily healthy. This patient is primarily healthy. He just had his heart failure recently diagnosed. So this patient came to us in February, and his heart failure was diagnosed in January. And he actually was told that when you notice that you're gaining weight, et cetera, take a little more diuretic. So at home, he's taken a lot of diuretic and he's over-diuresing himself. Now, this is his first metabolic panel. So first of all, look at his BNP. Remember, anything greater than 100 is abnormal. Greater than 200 absolutely relates to heart failure. And look at your patient, 2,510. He's in heart failure. His serum sodium is low. That's not uncommon. When we see somebody with cardiorenal syndrome and we see somebody with heart failure and with renal failure, it's not uncommon to see that the sodium is low and also to see that the water load is high. And we're going to evaluate that by looking at your serum osmolarity. Osmolarity is the content of your particles dissolved in the water. And you can see that he's just at the edge of low normal content. 275 to 300 by this laboratory report is the normal osm, and you can see his is 276. His urea is up, his creatinine is up, all in direct relationship to what's happening to him. And something else that's really, really, really important is he's been over-diuresing himself, or trying to over-diurese himself with Lasix, wasting a lot of salt and also wasting a lot of potassium. He also, and we already looked at the BUN and creatinine, but what we also see on this patient is his total serum CO2 is 34, which actually is alkalotic. So bicarb, total serum CO2, bicarb is up, base is in excess. And you're like, how could that be? Doesn't the guy have renal failure? Why isn't he acidotic? Because when you over-diurese, you actually are promoting the wasting of your metabolic acid. But underlying that, you may actually have metabolic acidosis. So we're going to call this diuresis-induced metabolic alkalosis with metabolic acidosis underneath. And we know that because you have a high anion gap. That's what's telling us that you're actually acidotic. Okay. Here's his EKG. Not really that remarkable. He's got a prolonged PR interval, but other than that, not so remarkable, except that if I look at the P wave in V1 and the P wave primarily in lead 2, you'll see that it's kind of sharply spiked and tented. That may be what we call P pulmonale, indicating that our patient may have some pulmonary hypertension. The EKG interpretation on the computer was not 100% correct, but what I'm going to tell you, this patient looks like he's had an old anterior MI. He actually has a left axis deviation, and I think he has left anterior fascicular block. Okay, way beyond what we're talking about here. I'm just telling you how I'm looking at his EKG. He has very poor transition of electrical activity across the precordium. We call that poor R-wave progression, and he has a prolonged PR interval. And by the way, he gets a fair amount of diuretic, but he doesn't urinate despite the diuretic. So we give him 20, then we give him 40, then we give him 60, and then we give him 80. He's not making any urine. This is a big clue. Usually if patients don't diurese, it's because they are arterially hypovolemic. Okay, here's his chest x-ray. So his heart's quite big, has some mild infiltrates. And again, these lines right here that actually are vertical, those are called the curly B lines, which indicate heart failure. You didn't need that to know the patient was in heart failure. Big heart, BNP 2500, sodium low, osm low, pretty worried. So of course, what we're going to get, we're going to think about is an echo. So I want you to look at his echo prior to admission. This is when he was diagnosed as having left ventricular failure. Look at, this was just a short time before he comes to us. He's diagnosed as having left ventricular failure with an EF of 15%. Okay, so he has profound systolic dysfunction. That's called reduced ejection fraction. HF, heart failure with an REF, reduced ejection fraction. His right ventricle is also dilated. Right ventricular systolic function is moderately reduced. The guy is in trouble. Cardiology comes to see the patient. He's in the ED. Remember that was his echo from 2-3. We're talking about admission 213. Now we're on 214, Valentine's Day, the day of the heart. And here comes our cardiology note. So I've taken out a lot of the other extraneous notes because I just want us to have the point for this patient and the important point for this patient, which is, oh, I will definitely, Clara, thank you for asking that question. I'll come back to that in a second. Okay, so he has reduced ejection fraction, 15%. He is arterially hypovolemic. He might even be total body hypovolemic because he's been over-diuresing himself. So I want to remind you that when you diurese the patient, when they are wasting urine, they can actually have severe metabolic acidosis, but because you've been diuresing them, you are wasting the acid. They still have the metabolic acid state at the cellular level, but I'm not going to see that because the diuresis has promoted the wasting of their metabolic acid hydrogen, which is a great thing. But now when I look at his lab work, I see that his bicarb is elevated, but he also has a wide anion gap, okay? So his bicarb is up, but he has a wide gap. You now say, oh, This is diuresis-induced metabolic alkalosis, and it's masking our metabolic acidosis. So he has absolutely got acidosis. His lactate level was 6.5. We would have expected his gap to be much wider. We would have expected his bicarb to be down, but because he's been over-diuresed, he's been wasting metabolic acids along with the urine, but I still am seeing signs of hypoperfusion because his lactic acid level is elevated. So that's how we know that. Okay, so cardiology says, hey man, this guy has really been over-diuresing at home. He's hypokalemic. That suggests that he's over-diuresed. He seems like he's hypovolemic. We believe he's over-diuresed. He eventually admits to taking double-dose diuretics, trying to get rid of fluid. And this is what I'm going to call contraction alkalosis, which masks metabolic acidosis. See that initial BAM? That wasn't the cardiology note. That was my addition to this note saying he has contraction alkalosis masking his metabolic acidosis. So cardiology says, stop giving diuretics right now. Give him a little bit of fluid. And tomorrow, I'm going to consider Bumex. Instead of Lasix, I'm going to consider Bumex, see how he makes urine after we give him a little bit of fluid. He's continuing on his beta blockers. We're going to hold Farxiga and we're going to hold losartan. Losartan, of course, as you know, is a combination of an angiotensin receptor blocker, and Farxiga is for diabetic management. And they want to restart aldosterone or aldactone, spirolactone. That's going to support the reabsorption of potassium and the wasting of salt and water. So might be kind of problematic, but okay, that's what we're going to do. Cardiology said it. We're going to obey pretty much what they've said. I want you to see where we are now with his labs, okay? So again, his potassium is low, his sodium is low, his BUN is high. Creatinine, when he first came in on 214, 8:43 a.m., sorry, 213 at 11 a.m., creatinine was 2.2. The next day, the next measure, that's a couple hours later, 2.2, and the next day, it's a little bit better. Now, it's a little bit better because we've given some volume resuscitation to the patient because he's hypovolemic. His glucose is mildly elevated. We wouldn't treat that. We don't consider that to be profoundly abnormal. And you can see he has some clotting deficit. He also has an elevated BNP, right? Because he's in heart failure. Okay, his troponin, his first troponin occurred on 2/3 and at 1:25 p.m. is 23, and by 5:45 p.m. it was 15. So his troponin is going down. Okay, it's pretty high to begin with, but now it's just on the edge of normal with his HS troponin. Okay, mostly status quo until 4:32 on 216. The nurse says, hey, patient's tachycardic, heart rate's in the 140s. He denies chest pain, shortness of breath. His blood pressure seems pretty normal. His oxygen is 100%. His respiratory rate is 18. I'm calling the physician because I'm really concerned about this tachycardia. Now, whether or not it was sinus tachycardia, I don't really know. Physician says, guy needs an ICD. I don't know why he said he needed an ICD because of sinus tachycardia. There was probably something else that occurred that I might not know about. So that's really important. Hold his spirolactone. Patient's creatinine is now up. His lactic acid is up. He is now actually progressing. Okay, this is why, right? So the doc comes to see the patient with a narrow complex tachycardia. Heart rate goes up a little bit more. They say, okay, he's feeling short of breath and feeling kind of lousy. I'm going to give him 6 milligrams of IV adenosine. Okay, I'm not that comfortable. Rapid response nurse says, I don't want to give adenosine. I really think the beta blocker is better. The doc says, I don't want to give beta block. I want to give adenosine. So physician says, listen, I don't want to give the patient beta block therapy because of congestive heart failure. So rapid response is saying, give beta block. Doctor is saying, don't want to give a beta block. I want to give adenosine. Nurse is saying, I'm not comfortable giving him adenosine. Doesn't really qualify for adenosine. So they come to some other agreement, and that agreement is amiodarone. Okay. Cardiology says, please don't give a beta block. Patients in heart failure. Remember that. We don't give beta block to a patient in heart failure. We give beta block to someone who's having an MI, but you're in heart failure. We're probably not going to give you a beta blocker. Always remember that. So they all agree pretty much that they'll start the patient on amiodarone if the heart rate is elevated. So Here, the rapid response nurse is having a disagreement. They do come to resolution. The physician documented that really well. The nurse didn't document it at all. It was kind of weird that the nurse doesn't document it, but the physician says, well, rapid responses, they don't want to do this and they want to do something else. Okay, but really neither one of you were right. We shouldn't have given adenosine. We shouldn't have given beta block. And the issue would really be to give the patient amiodarone. But now you can see this, I wouldn't call this sinus tachycardia. I actually think this is a pretty significant tachycardic response. I'm not sure that I can actually even make a case that I can see a P wave. I'm not sure. I think this is a supraventricular tachycardia. If it's supraventricular tachycardia, I might give adenosine. Okay, so now cardiology comes to look at the patient the next day, 216. He says, oh, he's now in much worse failure and he's in a low output state. His EF was 15% before, but now he really seems to have gotten worse. He's in cardiogenic shock. Again, another patient in cardiogenic shock. So blood pressure 90s to 80s. So we're not going to give Lasix because that promotes dilation. So they gave hydralazine to try to promote better diuresis and starting the patient on dobutamine. For me, you would have been on dobutamine a while ago. I would have started your dobutamine earlier. Might have felt really worried about that because you had this very rapid rate, and I know dobutamine is going to stress the heart. So I might have been concerned about that. So now the doc says, let's do an SVO2. Patient's got a PICC line. Let's continue the dobutamine and perhaps even advance the dobutamine. And let's consider placing a midline for aquapheresis or a VAS cath for ultrafiltration, because I've got to decongest my patient. They didn't look at his CVP, but he had obvious signs of venous congestion. Okay, so now I just want you to take a look. So they did put in a CVP on day 3. I'm sorry, because I forgot that. So here's his MAP 70, here's his CVP 28, his mean perfusion pressure is 43. On day 4, mean arterial pressure 68. So you thought things were just so great. You're so happy with your patient's mean arterial pressure until you look at your CVP. And you remember MAP minus CVP equals mean perfusion pressure. Patient is not perfusing. Even on day 6, mean arterial pressure 68, CVP is dropped because now we're really diuresing. We've started on dobutamine. Patient's got better forward flow, but his mean perfusion pressure is only 50. By the way, we're gonna have a renal infarct, and indeed, patient does actually infarct his kidneys. Okay, so now we're going to put that patient now on day 19. He's getting worse and worse and worse and worse. He's volume overloaded, volume overloaded, volume overloaded. So now we are going to place the VAS cath for CRRT. So just as a reminder, when we looked at our patient in the very beginning, he has metabolic alkalosis induced from diuresis, which means I lose a lot of the potency of the information that really tells me about my patient at risk. The only thing I really have here is his anion gap, which is mildly to moderately elevated for the first couple of days that he's in the ICU. He has cardiorenal syndrome type 1. One of the most important things you can do to prevent the evolution and the destruction of the kidney is maintain a mean perfusion pressure, MAP minus CVP. Everything that happens in acute heart failure, okay? So activation of RAS, activation of the sympathetic nervous system, signaling of humoral mediators that cause stress and destruction of the kidney, the intra-abdominal pressure, fluid accumulation, IAP is up, CVP is up, patient has venous congestion, a low cardiac output, and then sometimes that low cardiac output being caused by using ACE inhibition, diuretics, contrast agents, which promote vasodilation. In the end, you can have some acute kidney injury. As the kidneys become more injured, your heart failure will get worse. As the kidneys become more injured, listen to what I said, your heart failure will get worse. When you have heart failure, your kidney failure will get worse. You've got to step in here at some point. And even if you are not promoting the right consideration, at least have discussions. Should we be using diuresis? Should we be considering dobutamine? Should we be considering a VAS cath or a midline? Midline for aquapheresis, a VAS cath for ultrafiltration. Should we be doing that? I guarantee you that you as a bedside nurse, when you bring that up, your physicians are going to be more likely to consider it. Typically, physicians step back from CRT because they feel like nurses are not happy when we start CRT because our workload gets worse. Okay, that's why they call it work, because we need to help our patient. He may need CRT, and we should be discussing that early on. So we think about all the evidence that we see, that we saw in both of our patients. Heart rate's up, CVP is up, weight is up, creatinine is up, stroke volume, cardiac output, or ejection fraction, or all three are down. Urine output is down. MAP, or pulse pressure, is down. Mean perfusion pressure, or what we could also call renal perfusion pressure, is down. I have a lot of evidence here. I didn't need a PA catheter. It's helpful to have an echo. I always want to have an echo because that really is going to tell me about your ejection fraction. But if I have an A-line, I can look at your stroke volume. That's a poor man's method to look at an ejection fraction. I need to do something about it. I can't just write down all these things I'm monitoring and not do something. Gather all your data. Communicate with your team. Talk about how you're seeing what's happening. I've given all this diuretic, but my patient hasn't diuresed. He's getting worse. His venous congestion is worse. His creatinine is getting worse. His heart rate is getting worse. His kidney function is getting worse. His heart failure is getting worse. And I cannot decongest him with diuretics, because that's your purpose with diuretics, is to decongest the venous circulation. That's your purpose. You didn't do it. Patient needs for us to move forward and to actually think about how we're going to actively pull fluid off of that patient. So really, really important. So as nurses, we can monitor and keep that CVP down, decrease that venous congestion. Look at diuretics, look at your output, be vigilant, monitor it every hour, monitor the daily weight. I don't want to hear ever, our beds don't work. Those beds don't work. We put them on a bed where the scales don't work. Somebody forgot to zero the bed. The scales don't work. I don't want to hear that. Right? If the bed doesn't work, don't put a patient on it. Get another bed. Call biomedical engineering, get somebody who's more expert who can actually look at troubleshooting the bed so that we can be sure it works, because these patients must have daily weights and they've got to be accurate. And an excuse of saying, my beds don't work. Okay. Well, how long did you know that bed wasn't working? A month, 2 months, 6 weeks, 1 week, 3 days, 5 minutes before you put the patient in it? Don't put that patient in a bed that doesn't have a scale that works. You got to weigh your patient. That's really important. You got to control their heart rate. You need to be very careful with positive pressure ventilation when using PEEP, BiPAP pressure control, airway pressure release. You're putting a big burden on the right heart. That's going to cause more venous congestion. So pay a lot of attention to ventilatory management. Keep that MAP up as best you can. Really try to drive up stroke volume. Assure that your arterial waveform and the arterial pressure from your A-line is accurate. If it's accurate, I myself don't bother with non-invasive blood pressure. That's just something that's a panacea for the masses. I've got an A-line. If it's a good A-line, I'm going by the arterial pressure from the A-line, not from oscillated blood pressure, not even the same thing, not measured in the same arm, not the same measurement, doesn't really help me. But what I want you to remember is if you put your patient, give your patient a VAS cath, you're going to pay a lot of attention to PFR. PFR is the fluid you remove from the patient. Every time you put a patient on CRT, whether you're doing ultrafiltration or anything else, you must remove in the second hour. So in my first hour, I'm giving my patient 80 cc's of fluid. In that second hour, even if I don't want to pull fluid from the patient because they're too unstable, I'm going to remove the carrier fluids. Carrier fluids are fluids that I administer to the patient that carries medication in it. So whenever you go on any form of CRT, your commitment is to remove every hour the carrier fluids that were given the hour before. So in hour 1, you've got 80 cc's. In hour 2, I'm going to remove 80 cc's. The 80 cc's I gave you in hour 1, I'm going to remove in hour 2. In hour 2, you've got 80 cc's plus 200 cc's with your antibiotics. So in hour 3, I'm going to remove 280 cc's of fluid. That is just carrier fluid, and it gets your patient to what we call net zero. I'm not pulling fluid from the patient. I'm just removing the fluid that I'm giving them for their medication. Now, just think about that. If my patient, let's just say something easy. My patient gets 100 cc's per hour for 24 hours. That's 2,400 cc's. That's 2.4 kilograms positive weight. That is 2 liters positive fluid that I've given the patient. Once I put in a catheter, even if my patient's unstable, I'm going to try to always remove carrier fluids. You can do that effectively for these patients. And that, by the way, my friends, can actually help the worsening of their cardiorenal syndrome, their kidney dysfunction, and their cardiac dysfunction, if we just learn the right way to remove patient fluid. So we call that net zero. That means the fluid I'm giving, I'm taking out. When we start talking about net negative, it means I'm going to start removing fluid from the patient beyond the carrier fluid. So remember, if you got 80 cc's in hour 1, and my physician has said, I want you to remove 50 cc's from the patient, then I'm going to remove the 80 that I gave him plus another 50, and that will be 130 that I'm going to remove in the next hour. This is all, I feel like, really, 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 really important, that we really have to make commitments to doing the right thing about diuresing, decongesting, and patient fluid removal. It's in our hands. We can protect your kidney. We can try to protect your heart. We can try to improve your outcome by really evaluating effectively your response to diuretics. Did you decongest? Did you have urine output? Did your CVP come down? Did your peripheral edema improve? Did your body weight decrease? Simple things that are in my hands as a bedside nurse to actually try to improve outcome for patients. It's important to remember that kidney dysfunction is common in cardiac failure and shock patients. So not just in heart failure, but in all shock patients. And ineffective arterial volume is one of the major factors that causes renal infarct. Hypoperfusion, hypovolemia, cardiac failure, reduction in oxygen delivery. But it's also really important that in today's world, the evidence points to venous congestion being the single most important indicator of worsening renal dysfunction and something that we should manipulate. I gave you a diuretic, I expect your CVP to go down. I gave you a diuretic, I expect you to make urine. I gave you a diuretic, I expect you to start clearing your venal volume. You don't do it, I want to move forward. It's going to increase my work as a nurse, but it's going to improve your outcome as a patient. And that's really what I'm there for, right? That's why they call it work. It's going to be hard work, but I know all of you are really dedicated to doing the best thing for patients and really dedicated to trying to improve outcomes for your patients. So I want to say thank you very, very much. I really appreciate that you came on board to listen to cardiorenal syndrome. I'm also really grateful for your patience. I'm going to see you hopefully next week. And those on the call, please remain. I'm going to stop the recording, but then we can